At this time, I am delighted to feature our final speaker of the session, Dr. Iheme. She is the assistant professor in the Department of General Oncology in the Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center in Houston. She will be discussing breaking barriers, building trust, and finding solutions. Followed by her talk, she will join us on the panel where we will have time for a short Q&A session. Dr. Ada, please come up.
Hello, everyone. I gotta say, this is a very high bar, and I have to hopefully don't disappoint you guys. But thank you for all that you do, and I'm really happy to be here. I have been tasked with talking about breaking barriers, building trust, and finding solutions. Now, we've all seen the data, and there's no point going back and forth about it. No matter how you look at it, the numbers are pretty much the same. Black women and minorities in general are not doing well in clinical trial enrollment. If you look at the graph on the left side, this was from FDA clinical trials that led to FDA approvals, then you can see Black people are at the very bottom of that list, which is not good. And then we've all heard about it all day that there continues to be a mortality gap when it comes to survival in Black women, and we continue to do poorly. So we have a lot of things to do to change that. And one of those things is trying to enroll a lot more Black women in clinical trials, and as healthcare providers, as patients, as advocates, we have a lot of work to do. Now, when it comes to barriers, if you look at barriers in healthcare providers, there are a lot of them. One of them is poor physician and team communication. This is a big one. If you don't tell patients about clinical trials, they are not going to know about the clinical trials that we have. The other one would be physician and patient bias. Like in clinic 2 weeks ago, I was working with a resident, and they came and told me that, Mrs. Smith missed her last 3 appointments because she missed the bus. And you look at her chart, she has about 3 different things going on, and none of them are controlled. So naturally you think, oh, there's no point discussing this trial with Mrs. Smith because she's not going to do it, or she can't afford it, or she's not going to have transport to come in to get the biweekly or monthly trial. So that's a big problem. As physicians, we have to educate ourselves and educate our colleagues on these biases. And the good thing is ASCO, NTI, and all the big organizations are doing a better job of making sure that that is actually things that we do. Cultural differences and diversity in the workforce. This is the big one that we'll talk about in a minute. And providers not being aware of potential trials. One way to get around it is to email a friend, email a colleague. We all went to school together. If you're in the community or in a rural area and you have a friend who is in a bigger center, you can always email them and see if there are any trials that will be available to that patient. This is a really good study that I wanted to point out. It's a meta-analysis of rates of agreement of trials if asked. As you can see here, it doesn't really matter what race you are. If you were asked to go on a trial, you probably go on that trial. So this thought that, minorities and Black people don't go on a trial is not always true. Sometimes all you have to do is ask. This was a snapshot of the state of oncology from last year. And as you can see, Black people represent about 30.4% of the US population. As you go down each category, you see that that number decreases. About 3.9% of oncology fellows are Black, and even lower number of oncologists are practicing. If you look on the left side, the same thing, a lot of less Black people in the community workforce, in the oncology workforce. It's a big problem. So we have a lot of work to do to diversify the workforce. Now, does this mean that every person of color needs a physician of color? No. But we all have to be culturally competent and understand each other's culture so that we can make things better for everybody, including Black people. Patient barriers. We've talked about trust all day. Historically, there's been a generational mistrust in the healthcare system for multiple reasons, and that is unfortunate, but we have a lot of work to do in terms of advocating for ourselves and advocating for our patients to make sure that we enroll more people that look like us in clinical trials. Always follow your gut instinct as patients. If you don't like a physician or you don't trust them, find somebody else. Have a patient, have a family member or a friend refer you to physicians that they trust. That is very important. Ask a lot of questions as patients. Ask the doctors to show you the data and make sure that they communicate everything well with you. That way you're very, very well informed. Seek a second opinion if you don't like the doctor. That's okay. Seek a third opinion. Maybe if you hear if you hear the same thing from different doctors, you'll be more at peace with your decision to make. And of course, we all know about the social economic factor. This is a very big deal. It's always good to get patient advocates, case management, social worker, and clinical navigators involved to make these things easy. When it comes to barriers like limited eligibility, this is a big one. And ASCO has been doing a lot of work about it. In the past, we always want to have the perfect patient to be on a trial. You have to have this, you have to have that. Those things are not always realistic. And ASCO has been working a lot to try and improve enrollment of Black people in trials. One of those things is the ASCO and Friends Cancer Research. They issued a joint statement. And one of them is that we have to increase, we have to remove things like the washout period, which is, for those of you that are not medical, that means the amount of time your previous medication leaves your body. So now we're saying in clinical trials, do we really, really have to have washout periods? And if we remove that, maybe we will have more clinical trial and maybe we will have more people in trials that will add more Black people. Things like prior therapies, this should not be an exclusion unless it is potentially interacts with the other therapies that we get. And of course, performance status, gone are the days where we need patients that run 10 miles a day to enroll in trials. Now, we should be more realistic. We should make sure that we have people that, even those that have decreased performance status, should be able to have clinical trial eligibility. So this was from the ASCO Road to Recovery, and it was a volunteer workforce that came across to, it's pretty much relevant in trying to increase Black patients in trials. So what they're saying is we should try and start designing pragmatic trials that would be easily integrated into the routine clinical practice. And also we should allow for more local and remote treatment of treatments. As you know now, since COVID, with telemedicine, patients can be in rural Alabama getting treatment while they're on a trial in MD Anderson. So we have to make sure that we increase the use of things like telemedicine and having patients get their clinical trials remotely, maybe get their infusions in Alabama, and then maybe come to MD Anderson or whatever it is that they have once or twice a month to make these things work. So in general, trials have to be more accessible, equitable, and very realistic. Okay, so financial barriers, big deal, as we all know. Medical and non-medical costs. You see a patient in the clinic, they want to be on a trial, they need labs, they need x-rays, they need imaging, they need this. Who is going to pay for all of that? It used to be that private insurance and Medicare used to cover most of the routine care, and the Medicaid patients were left behind. But luckily, I think they passed a law. Was it last year or this year? They passed the law that now patients who are Medicaid get this cost covered. So that has kind of leveled the playing field. The non-medical cost is still a problem. Trial sponsors used to cover them before, but now due to ethical reasons and compliance reasons, they do not. So there is this Diverse Trials Act that is currently in the House, in the Senate, which obviously nothing works there, so good luck trying to get that passed. Okay. But hopefully, it's our hope that if and when it gets passed, it will bring clarity to trial sponsors being able to cover some of these non-medical costs and level the playing field to get more people enrolled in clinical trials. In case you don't believe me, there's actually a congress.gov, the Diverse Trials Act is over there. You can go read it. All right. So finally, again, the good thing is ASCO and the ACC and all the big people, they know that this is a problem and everybody is trying to work closely to improve it. And some things that they're saying is we have to educate our physicians. We have to educate our medical people. We have to, things like bias. We all have our biases. It's a big, big, big deal. And that's one thing that we have to do, be aware of the biases and try to change it. We have to have more stakeholders who are more involved with Black people, those who have the values and interests of Black people at heart, so that they can help to enroll more of these patients. And finally, we need to improve access to clinical trials. Everybody should have, everybody who has cancer should have opportunity to participate in clinical trials, wherever they are, in Alabama, in Ohio, wherever. So these are things that we have to fix, and hopefully that we can do that going forward. So thank you very much.